كل سنة وحضراتكم طيبين وبخير. اليوم حدث استثنائي، يعني حيث نبدأ ببكورة التعاون بين FRCR Egyptian Society and the Egyptian Society of Breast Imaging برئاسة الأستاذة الدكتورة رشا كمال، Professor of Radiology, Head of Women Imaging Unit Cairo University, Chief Consultant at Bahia Breast Cancer Hospital, President of Egyptian Society of Breast Imaging. أهلا بحضرتك دكتورة رشا.
أهلا بك يا دكتور محمد.
أهلا بحضرتك يا فندم، بنشكر حضرتك على المحاضرة، وإن شاء الله على وعد مستمر بالعطاء دايما للسادة الزملاء بالتعاون مع الأفاضل في جميع الهيئات والمؤسسات العلمية إن شاء الله. بداية موفقة إن شاء الله يا دكتورة رشا.
أبتدي إن شاء الله يا دكتور.
اتفضلي يا فندم. اتفضلي.
بسم الله الرحمن الرحيم. يعني at the beginning I want to excuse you all that I'll give the lecture all in English because I promised some of your colleagues that I'll do so because they asked for me to give it in English. يعني. Before I give my lecture, the recent updates in mammography, I just want to announce the the Society of Breast Imaging. It's not an independent society. It's a sub-speciality of the Egyptian Society of Radiology and Nuclear Medicine. يعني actually we can call it شعبة التصوير الطبي للسادي لأنها ليست جمعية مستقلة. إحنا جزء من الجمعية المصرية للأشعة. يعني وإن شاء الله يعني our main aim إن هو هيكون نشاطنا أغلبه تعليمي ومن كل أنشطتنا وإحنا تابعين إداريا وماديا وكل حاجة للجمعية المصرية للأشعة. فما إحناش جمعية مستقلة، وهي جمعية مش ملك حد، هي ملك كل أطباء الأشعة زي الجمعية المصرية بالظبط. يعني إن شاء الله لما هيبقى فيه هنعلن عن بدء الاشتراك في الجمعية، هيبقى برضو الاشتراك من خلال الجمعية المصرية للأشعة، وأي مشترك عندنا لازم يكون أصلا مشترك في الجمعية المصرية للأشعة. وإن شاء الله يعني هنبتدي نعلن عن شروط الالتحاق وكده على الأسبوع الجاي أو اللي بعده بإذن الله تعالى. نرجع بقى للمحاضرة إن شاء الله. بسم الله الرحمن الرحيم. There's a common saying which says that necessity is the mother of all inventions. And actually, I do believe in this common saying because our futures are always based on our needs and demands. And so I'll raise this as the slogan of my lecture today. Going back to breast cancer, over the past few years, we have witnessed a remarkable increasing incidence of discovered breast cancer cases. And in parallel to this increasing incidence, we have also witnessed dynamic changes in the investigation and management of breast cancer. It was found that the only way to curtail breast cancer is by coupling early detection together with a proper diagnosis in order to be able to give the patients the most adequate and appropriate treatment options. And of course, we as radiologists play a fundamental role in this part. And when preparing the arsenal to fight the war against breast cancer, mammography was and still remains the first-line defense. In spite of this, the technical advances in mammography lagged behind other imaging modalities. And the reason for this is that mammography has specific requirements of quality standards that was thought that digital imaging could not supply. Yet after the introduction of the hospital information system, the PACS, the filmless departments, and the teleradiography, it has become essential to move one step forward. And again, because necessity is the mother of all inventions, a new weapon had to be added to the diagnostic arsenal against breast cancer, and this weapon is the full-field digital mammography. The first full-field digital mammography unit was approved for sale by the Food and Drug Administration in the year 2000. I think it's difficult to believe that these two breasts belong to mammograms belong to the same lady just because she performed the mammogram above on a conventional mammogram and the one below on a digital mammogram. Yet in spite of this, the technical advances in mammography, it has always been accused of having major technical limitations. It was always accused of having a low sensitivity because the normal breast tissues may obscure an abnormality which is responsible for a large number of false negative results. It's also accused of having a low specificity because the superimposed breast tissues might give the impression of a false abnormality, which is responsible for a large number of false positive results. And we all know that the breast density changes from a breast ACR-A, which is a fatty breast, to the ACR-B, the scattered fibroglandular densities, the ACR-C, which is a heterogeneous dense breast, and the ACR-D, which is an extremely dense breast. And as we move from the ACR-A to the ACR-D, there is an increased risk of breast cancer development according to studies, and in the same time there is a reduced contrast between lesions and surrounding normal breast parenchyma. The challenge with mammography interpretation increases more whenever we have younger individuals, whenever we have a dense or a heterogeneous parenchyma, whenever we have non-distorting and non-calcified carcinomas. And sometimes we are accused of this challenge because we as radiologists might have a bad perception or misinterpretation to mammograms. I think if we all look at these mammograms, we can admit that lesions are easily detected and diagnosed in a fatty breast because we can all see the speculated outline mass lesions. We can all be definite that this is a malignant breast lesion. In contradiction to what we have just seen, this is another mammogram with a heterogeneous dense breast parenchyma, and we cannot see what's behind this parenchyma unless we perform an ultrasound examination, and we can see that there are multiple carcinomas within the left breast. Only going back to the mammogram, we can identify some subtle changes in the left breast, but we are only sure when we perform an ultrasound and not based on the mammogram. This is another example where we have a heterogeneous dense breast parenchyma, and unless we see the speculated outline mass lesion in the right breast and we identify the location of this lesion on the breast, can we go back to the mammogram and then we can see that there is an underlying speculated mass lesion in the right upper outer quadrant. This is another example. We have bilateral, multiple obscured mass lesions within both breasts. On the ultrasound examination, there was underlying fibrocystic mammary changes, but in between these cysts, we had this irregular shaped hypoechoic mass lesion. And again, only when seeing this lesion and going back to the breast and identifying the location of this lesion, we can only see the lesion on the mammogram when we do so. There was an underlying speculated mass lesion in the right breast. These mammography limitations were actually the driving force behind efforts to upgrade existing mammography technologies and develop newer ones offering enhanced detection and diagnosis of breast cancer, modalities that are affordable, fast, and in the same time applicable. And going back to our slogan that necessity is the mother of all inventions, a new weapon had to be added to the diagnostic arsenal against breast cancer, and this time it is the 3D digital tomosynthesis. I'll have a stop here and ask you if anyone has a question or no. Does anybody have any question or I continue?
في معانا دكتورة نيفين اللي له سؤال. السادة الزملاء والزميلات اللي له سؤال يتفضل يعمل انميوت لنفسه ويسأل.
أستأذن حضرتك, it means that mammography alone is not enough. We should always add ultrasound for the study.
It's not always, as I said, the challenge with mammography increases when we have a dense breast, when we have young individuals, when we have a heterogeneous breast. You see, it's so not in all cases.
Yes, during screening, if I get dense breast or young patient, I should add ultrasound in screening.
No, we don't screen young individuals.
Maybe in high risk.
Screen young individuals. In high risk, we start, it's okay. And in high risk, it's indicated that you perform not only an ultrasound, but an ultrasound and an MRI. But you should know who are the high risk individuals in the first place. The high risk individuals are those individuals who have an incidence more than 25% more than the general population, and they are specified as those who have BRCA mutation, those who have had direct irradiation to the chest when they were young, when they were in their childhood, and those who have some familial syndromes. For example, some of the familial polyposis, the same gene which causes the polyposis causes breast cancer. So it's not only indicated ultrasound. And whenever you have a dense, heterogeneous, dense breast on screening for a normal individual, we sometimes have to recall the lady, and sometimes this lady must get a notice that she should do something more in her next screening, that she should be screened with mammography and ultrasound, or if we have tomosynthesis, and we're going to speak about this now, it should be added to her screening protocol.
Thanks a lot.
Any other questions? So we'll continue. The first 3D digital tomosynthesis was approved for sale by the Food and Drug Administration in the year 2001. 3D digital tomosynthesis is expected to resolve many of the tissue overlap reading problems that are considered a major technical limitation of digital mammography. The technique of 3D digital tomosynthesis is simple. It's exactly like a mammogram, where the breast is placed here in between the compression plate and the digital detector. But what's different from the mammogram is that the X-ray tube moves in an arc across the breast, taking a series of low-dose images that are acquired at different angles. The total dose of these small low-dose images is equal to or slightly higher than the single-view mammogram. The end result is that we get a 3D reconstructed image of the breast that can be viewed every 1 millimeter. The clinical applications of tomosynthesis includes detection and screening, because using tomosynthesis, we can detect more cancers, and in the same time, we can reduce the recall rates. It's also applicable in the diagnostic context, because using tomosynthesis increases the diagnostic confidence, or in other words, it helps us decide whether this lesion is benign or malignant. Using tomosynthesis, we can reduce unnecessary biopsies, we can identify the actual tumor size, and we can identify multiple lesions within the breast, and all this is more pronounced whenever we have a dense breast parenchyma. And now we'll have a look on the use of tomosynthesis in screening. As I've just said, using tomosynthesis can help us detect more cancer. This is an ACRC breast, which is classified as an ACRC, or it is towards a dense breast. And we can see now this oblong-shaped circumscribed mass lesion, which on complementary ultrasound examination turned out to be a small adenoma. The rest of the breast showed fibrocystic mammary changes. However, doing the tomosynthesis, we found something more serious than what we have just said on the normal mammogram. Doing the tomosynthesis, we identified a speculated outline mass lesion seen in the upper outer quadrant of the right breast. A biopsy was taken and revealed an underlying invasive lobular carcinoma. This is a less dense breast. It is classified as an ACRB. And could anybody of you help me where the lesion is in this breast? It's not a dense breast. Would anybody want to answer? Okay, whenever I show this mammogram,
it's on the left breast, outer inner
yes.
aspect of the left breast.
In many cases, they tell me that this is the lesion. Okay, but the true lesion, it's not this one. It is here, a speculated outline mass lesion, and it is seen more evident on the tomosynthesis image. We had an underlying speculated carcinoma. This is an even less dense breast. It was classified as an ACRA, and it was assigned a BI-RADS 2 based on the fact that she has an intramammary lymph node in the right breast. Actually, on the tomosynthesis, it was not an intramammary lymph node, and when we see the tomosynthesis and we see the speculated outline, then this is a small carcinoma. A biopsy was taken, and it revealed an underlying invasive duct carcinoma. As we've just said, the tomosynthesis also helps us to decrease the record rates. This was a screening mammogram of a 55-year-old patient. She was going to be recalled because of this speculated outline mass lesion in the upper outer quadrant of the right breast. Actually, on the tomosynthesis, this was not an actual lesion. It was just overlapping breast parenchyma, which gave a false impression that there was a mass lesion within the right breast, and this patient was not recalled. And now we'll have a look on the use of tomosynthesis in the diagnostic context. As we've said, the tomosynthesis increases our diagnostic confidence. This is a 52-year-old patient with a palpable left retroareolar mass lesion. On her mammogram, we can hardly see a focal asymmetry in the left retroareolar lesion. We are not definite that whether this is a lesion or no. But looking on the tomosynthesis images, we are definite that there is a speculated mass lesion in the left retroareolar region. And this was her complementary ultrasound examination, which revealed an irregular hypoechoic mass lesion with posterior shadow. This is another lesion. This is another case. She had rounded, circumscribed, moderately dense lesion in her right breast. She could have been assigned a BI-RADS 3, but when looking on the tomosynthesis again, we can see that this lesion is not as good as it appeared on the mammogram. It had speculations, and the outline was obscured in part of the lesion. And a biopsy was taken again, and it revealed an invasive duct carcinoma grade 2. This is another case. She's a well-known case with focal right upper outer quadrant fibrocystic mammary changes. Looking on the tomosynthesis, we thought that these are the focal fibrocystic mammary changes, but looking on the tomosynthesis, this lesion, which was just adjacent to the big lesion, it had an irregular appearance with a speculated outline. We performed an ultrasound examination. This was the cluster of cysts, and this was there was an adjacent irregular speculated mass lesion. This was the elastography of the same lesion, and having this blue color on elastography means that we are dealing with a malignant mass. This is another case. There was a bilateral upper outer quadrant nodular lesions, which were thought to be intramammary lymph nodes. Again, looking on the tomosynthesis lesion, the lesion on the right was an actual intramammary lymph node with a central fatty hilum, while the lesion on the left was irregular in shape with a microlobulated outline. A biopsy was taken from this lesion and revealed a small, tiny invasive duct carcinoma. As we've just said, the tomosynthesis helps us identify the actual tumor size. If we all look at this mammogram, it's very clear that this is a malignant lesion with a speculated outline. And you might think, why should we perform a tomosynthesis in such a case? But just compare what we see on the normal mammogram with what we see on the tomosynthesis. And when we have a closer look at the extension of the lesion on the tomosynthesis and its extension on the mammography. And I think identifying the tumor size is actual tumor extension counts in the patient management. This is another example. This is again an evident lesion with a speculated outline. It is an evident carcinoma on the mammogram, and this is how it appeared on the tomosynthesis and how it appeared on the contrast mammography. Just compare the size on the tomosynthesis, the size on the normal mammogram, and the size of the lesion on the contrast mammography. Definitely the lesion extension was more evident on the tomosynthesis than it was on the mammogram or the contrast mammography. This is another case. We saw nothing on her mammogram except that she had this posterior tenting of the breast parenchyma, which sometimes indicates that there is an underlying lesion. But actually on the mammogram, we saw no definite lesion. While looking on the tomosynthesis image and having a closer look, there was a speculated outline mass lesion, and it was not only one mass, there was another mass in the inner breast quadrant, and this was a multicentric carcinoma of the left breast. And now the question comes, has 3D digital tomosynthesis solved all the problems of breast imaging? We all know that the best results in imaging are usually obtained from imaging modalities which can combine both morphology assessment together with functional information. And yes, tomosynthesis provides us with an enhanced morphology assessment, but it has no role to play in giving us any functional information about breast lesions. And so we go back to our slogan again, that necessity is the mother of all inventions, and a new weapon had to be added to the diagnostic arsenal, and this time this weapon is the contrast mammography. I'll have a stop here and ask you if anybody wants to ask any question.
Dr. Rasha?
Yes?
Is this meaning tomosynthesis essential?
Your voice is not clear at all. Can you please higher your voice?
Okay, just a minute. That's good now?
Yes.
بس حضرتك كده معناه ان احنا التوموسينثيسيس ده اساسي في كل حاله. الحالات اللي حضرتك عرضتيها يعني في حالات ما كانش فيها شك اصلا، سواء اذا كانت دي كانسر او ان دي ما فيهاش كانسر، والتوموسينثيسيس كان العكس خالص.
Your question is a very good question على فكرة.
ممكن يحل في يوم من الايام محل الميمو.
Your question is a very good question. It has two parts. Can tomosynthesis replace mammography? And the first part of your question is, should we perform tomosynthesis for all cases or no? Okay. If you have tomosynthesis on your mammography machine, then every individual performing a mammogram should perform at least a single view with a tomosynthesis. And why this? Because tomosynthesis actually helps us mainly in identifying lesions that we do not know that they are present or that they are already present. So just perform a single view with tomosynthesis just to exclude that there are no underlying lesions. Okay? The second part of your question is whether tomosynthesis will replace mammography or no. Actually, when you do the tomosynthesis in the new machines, you get a reconstructed image, which is exactly, we call it a synthetic image, which is exactly like a 2D mammography image. And that means if you perform tomosynthesis, you can get the tomosynthesis images, which are viewed every 1 millimeter in slices, and you can get in the same time a 2D image, which is exactly like the mammogram. So if you perform tomosynthesis, you do not have to perform a mammogram because we get the same result from tomosynthesis. Okay? Is that clear? You need to ask any question.
Please, I can do
Hello.
Okay. Can I finish my question, please?
Yes.
Hello.
This means if I have tomosynthesis, can I?
Hello.
Can I do it from the start?
Do tomosynthesis? I don't understand. I don't hear the rest of your question.
يعني أنا لو عندي توموسينثيسيس في الماشين بتاعتي ممكن أعمل توموسينثيسيس من الأول وبلاش الماموجرافي أصلا؟
أيوة ما هو أنت you get a 2D image from the tomosynthesis image. You actually get a mammography and the tomosynthesis from just doing a tomosynthesis. Okay?
Okay, thanks.
Any other questions or I continue?
تقدري حضرتك اتفضلي يا فندم، تقدري حضرتك تكملي.
The first contrast mammography was approved for sale by the Food and Drug Administration in the year 2011. In contrast mammography, it is simply a mammogram after injecting a contrast in the antecubital vein. We use the normal low osmolar contrast media that we use in CT. We inject them in the antecubital vein, wait for 2 or 3 minutes, and then we perform a normal mammogram in the two views, the two conventional views, the CC and the mediolateral oblique view. What's different from the normal mammogram is that in each mammography view, we get a pair of images. One is called the low energy image, which is exactly like the mammogram. It looks exactly like the normal mammogram. We do not know when we look at the low energy image that we have contrast in the image. And we get a high energy image, which is highly sensitive to the presence of iodine. Then we subtract both images from each other, and we get the subtracted, or they call it the recombined image, in which the parenchyma is totally canceled, and what we see only on the mammogram is the lesion which shows contrast uptake. But we always have to remember that in addition to this subtracted or recombined image, we still have the low energy image, which looks exactly like the mammogram, and this is a valuable image in which we can see micro calcifications. I'll show you one case in which we performed tomosynthesis, and still we needed to perform contrast mammography. Can you please mute your phone? I'll put you on mute all. Okay, this was a 38-year-old female, 35-year-old female with a palpable left breast mass lesion. Corresponding to the left breast mass lesion, she had this lesion on the mammogram, which was a speculated outline mass lesion, which even became more evident on the tomosynthesis image. Unfortunately, during performing an ultrasound examination, we found a tiny lesion in the contralateral breast in the right retroareolar region. We went back to her mammogram and to the tomosynthesis, and we were not sure whether there was a lesion or whether this linear opacity corresponded to this lesion or no. According to the breast cancer tumor board, she was assigned for a contrast mammogram. When she performed the contrast mammogram, actually the lesion on the left was not a single lesion. We saw multiple lesions, and the lesion on the right appeared enhancing in the right retroareolar lesion. A biopsy was taken and revealed bilateral invasive duct carcinoma. We performed several studies in Qasr Al Aini, in Bahia Hospital, and in the National Cancer Institutes about contrast mammography and its clinical use. And the clinically proven results of these studies have shown that contrast-enhanced mammography increases mammography sensitivity and specificity. In other words, we can say that more patients will be sent home avoiding further workup, or in other words, we can help reduce patient anxiety. And in the same time, less cancers will be missed, or we will have an enhanced diagnostic performance. To achieve proper patient management, whenever we encounter a case with a suspected breast cancer, we are always asked to pass through 3 steps. The first step is we have to look for cancer, or to detect and diagnose cancer. Then we have to stage this cancer or know how far this cancer has spread. And lastly, we have to follow up this cancer, and when this cancer has been treated, we have to follow up the patient or determine if the treatment that we have given to the patient has worked or not. And we'll start by having a first look on the detection and the diagnosis of cancer using contrast mammography. In a study assessing the impact of using the MRI morphology descriptors in the characterization of 350 breast lesions, we found that most malignant tumors show contrast uptake, and most benign tumors do not show contrast uptake. But there is still an overlap between enhancing benign and malignant lesions. But we can simply say that whenever we have a breast lesion which is non-enhancing, 99% this lesion will be a benign lesions with very few exceptions, and this is the low-grade ductal carcinoma in situ. I'll show you one example which proves what I've been just saying. This was a 50-year-old female. She had bilateral nodular texture of her breast parenchyma, and looking at her breast, she had bilateral multiple nodular lesions in both breasts. We performed a contrast mammogram, and all the lesions on the right side did not show any contrast uptake, and actually they were small fibroadenomas, and all the lesions on the left side showed contrast uptake, and this was a multicentric invasive duct carcinoma. This is another case. She's a 27-year-old lactating female. She had a rapidly growing left breast mass lesion. This was her ultrasound. She had a circumscribed, highly vascular mass lesion with slit-like spaces, and she was misinterpreted as a spheloidous tumor. We performed a contrast mammogram. This was the low energy images, which, like I told you, they look exactly like a mammogram, and we could not identify the lesion. Well, and on the subtracted or the recombined images, the lesion did not show any contrast uptake, which indicated that this lesion is most probably a benign lesion. A biopsy was taken, and it was simply a lactating adenoma. And up till now, we have no morphology descriptors specific for contrast mammography. So we follow in characterizing lesions on contrast mammography, we follow what we do on MRI. The same descriptors used for MRI are used for contrast mammography. And so whenever we see a lesion that is enhancing on contrast mammography, this lesion is classified into an enhancing focus, which is less than 5 millimeter, and it is non-space occupying. It is into mass lesions, which is a 3-dimensional lesion, and it is space occupying, or non-mass lesions, which is an area, and it is a non-space occupying. And to characterize whether this enhancing lesion is benign or malignant, we should describe the shape of the lesion, which is either rounded, oval, or irregular. We should describe the margin of the lesion, which is either circumscribed, irregular, or speculated, and we should describe the internal enhancement of lesions, which is either homogeneous, dark septations, heterogeneous, or rim enhancing. Going to the left side, we are mainly speaking of benign lesions, and going to the right side, we are mainly speaking of malignant lesions. Or in other words, if I say that I have a rounded lesion, which shows circumscribed margins and homogeneous enhancement, or it shows dark internal septations, then this lesion is most probably a benign lesion. While on the other hand, if I describe a lesion and I say that it has an irregular shape with speculated margins, and it shows either heterogeneous or rim enhancement, then most probably this lesion is malignant. And when we have enhancing non-mass lesions, we should, to characterize them, we should describe the distribution, which is either focal, linear, segmental, taking a distribution of the duct, regional, taking more than one segment, more than one quadrant, multiple regions, or diffuse enhancement. And we should describe the internal enhancement characteristics of the non-mass lesion, which may be either homogeneous, heterogeneous, clumped, or clustered rings. And we found, according to several studies, that the linear, the segmental, and the regional distribution, and the heterogeneous and the clumped pattern were the most significant of malignant lesions. Contrast mammography actually has the potential to be used in screening high-risk individuals like this one, and usually high-risk individuals have this type of heterogeneous dense breast with multiple areas of concerns. But where the true area of concern is only seen on the contrast mammography. See how all this heterogeneous dense parenchyma is cancelled on the contrast mammogram, and we can only see these two tiny enhancing nodules in the left breast, and actually this was a multifocal carcinoma of the left breast. And now we've diagnosed the carcinoma, and the next stage is that we have to stage this carcinoma, or in other words, know how far this carcinoma has spread. And to stage any carcinoma, we should identify the size of the lesion, the multiplicity of the lesion, the lymph node status, and the distant metastasis. And actually, in contrast mammography, what we can only do is identify the size and multiplicity of lesions. This is a 38-year-old female with a palpable right breast mass lesion. Corresponding to the clinically palpable lesion, we had this small lesion, and she was said to be a good candidate for a conservative surgery. When she was addressed in the cancer tumor board, the breast cancer tumor board, again the surgeon said we cannot perform a conservative surgery in such a heterogeneous dense breast. And although we see this lesion, we are not sure that there are no more in both breasts. We did a contrast mammography. Her left breast was totally free, while her right breast showed a much wider extension of the lesion, And according to contrast mammography, the management of this patient was changed from a conservative to surgery to an MRM. This is another case. She's a 47-year-old female with a palpable left breast mass lesion. Again, she was a good candidate for conservative surgery, but on her contrast mammography, unfortunately, it was not a single lesion, although this patient did not have this dense breast that the last patient had. But yet, the contrast mammography showed additional lesions that were not seen on the normal mammogram. And again, the management here changed from a conservative to an MRM. I'll have a stop here and ask you, does anybody want to ask any question?
Hello. Hello.
Hello.
Yeah. Ma'am, I want to ask what is BRCA1 and BRCA2 mammography?
Can you handle your voice, please?
I want to ask what is BRCA1 and BRCA2 mammography?
The BI-RADS or the ACR? There are two classifications for the. You're talking about two classifications. The ACR.
No, ma'am. No, ma'am. No, ma'am. No, ma'am. I'm not asking about classification. I'm asking about BRCA gene mammography.
The BRCA gene.
Yeah.
Yes. Okay. Yes. I understand. These are some patients have some genetic mutation which makes them more prone to develop some types of carcinomas, and from these are the breast carcinoma with the BRCA gene 1 and 2. But we have also other genetic mutations which predispose to breast cancer, like I just told you, those who have familial polyposis. But I can't remember the name of the gene, but there are other genes which predispose patients to develop breast cancer. Is that clear? Or
no, ma'am, I want to ask, like, what do we do in those? Like, how do we do it?
How we manage these patients?
No, how do we do the procedure? How do we do the procedure of mammography to detect that BRCA gene 1 and BRCA 2 mammography?
They are not detected by mammography. They are detected by genetic or chromosomal studies, genetic studies. They are not detected by mammography. We just suspect them on mammography when the patient comes and she tells you that her mother, her sisters, her aunts have had breast cancer, and then you see this type of heterogeneous dense breast parenchyma. We sometimes advise the patient and tell her you have to do to test for your genes because most probably you have a familial tendency to develop breast cancer.
So, is contrast enhanced spectral mammography better than the simple mammography in these patients?
Yes, it is, but we have limited studies up till now. To a recent publication in 2019 said that the contrast mammography is useful in patients with familial tendency or with increased tendency to develop breast cancer. But we have not a good amount of studies to prove this, because especially that they say that these patients have a more sensitive parenchyma to the increased irradiation. So we have to do a prolonged studies to know whether doing contrast mammography will increase the risk or no. You see the difference? And that's why what is documented and validated that these patients should be screened by mammography and MRI. Some do it annual, starting the age of 35, not the age of 40, and some do it every 6 months, once you do a mammogram and once you do an MRI. But I think in the near future, the contrast mammography will prove itself as a good screening tool in these individuals, because most of them, they do their mammograms and they do not do the MRI because it's more expensive and it's more difficult to get a date to perform an MRI. While doing contrast mammography, you are obtaining the benefits of both MRI and mammography together. But as I've just told you, we have to perform prolonged studies as to determine whether using contrast mammography will have an effect on increasing the incidence, the development of breast cancer or no.
We had.
Excuse me, doctor.
Hello.
Doctor, what about dense breast? Is the contrast enhanced mammogram better or the MRI?
In contrast mammography, actually, the advantage over MRI is that it is easier, cheaper, and if you have it, it's very easy to put it in your to add it as an add-on exam in your routine work. And in the same time, the parenchyma does not enhance much on the contrast mammogram like it does on the MRI whenever you have a dense breast. So sometimes, in most cases, whenever we have a contrast mammography available, for me, I prefer to perform a contrast mammography in the dense breast more than I do for do an MRI. But there are special situations. I have a specific lecture to identify when should we perform MRI and when should we perform a contrast mammogram. But it is a very long lecture. I cannot give it. I cannot even simplify it here. But I'll tell you that usually we take the decision in the tumor board according to each situation. I'll give you a few examples. For example, we have lesions that are difficult to be detected on a mammogram, like the deeply seated lesions, the axillary tail lesions, lesions in the inframammary fold, in the upper inner quadrant. So these lesions sometimes are missed on the mammogram. So I can never ask if the patient, for example, comes complaining of a mass in the upper inner quadrant, in the inframammary fold, I never recommend contrast mammography in these cases because they are already easily missed on the mammogram. So I might perform the contrast mammography and see nothing. There are multiple situations where MRI is still very much superior than contrast mammography, but this is actually a very long, I need to speak for maybe half an hour to explain this. Any other questions?
Excuse me, ma'am. One question about the contrast enhanced mammography, ma'am. What exactly procedure you're following in your clinic, ma'am? How much the dose and the timings?
The dose and the timing, it's 1.5 cc per kilogram. We usually give, we say the average person is 70 kilograms. He usually receives about 100 cc of contrast. We inject the contrast, we wait for 2 minutes and 2 to 3 minutes, and then we start doing the cc of the normal side, the cc of the disease side, the mediolateral of the disease side, and then the mediolateral of the normal side.
معانا دكتور أحمد منير. We have Dr. Ahmed Munir have a question. اتفضل.
Dr. Rasha, I have a question. Is there what's the difference between microcalcification in mammography and the tomosynthesis regarding the morphology? Is there any difference between both techniques?
When tomosynthesis, when we started practicing with tomosynthesis, it was accused that because we see the slices every 1 millimeter, it was accused that we can miss microcalcific clusters because of this. And they said that the normal mammogram is much, much better than the tomosynthesis for identifying microcalcifications. And also the technique of performing tomosynthesis sometimes caused with calcifications in general, it caused like something, they called it a tail artifact. And this artifact can blur the image so that you do not see the tomosynthesis clear. But now the new machines, and in special types of machines, they added that you can see the tomosynthesis images in 2 ways. You can see it in a very thin slices of 1 millimeter thickness, or you can see it in slabs of 1 centimeter thickness. And when you see it in a 1 centimeter thickness, you no more get the problems that tomosynthesis was accused of, because you can see a microcalcific cluster very evident. I have very good cases where we cannot identify microcalcifications on mammography because of a dense breast, and then doing the tomosynthesis, they are very evident. Using the slabs, we can identify the cluster, and using special techniques in the tomosynthesis, we no more see this tail artifacts which follows the calcification and blurs the image.
Yeah. I have another part of the question. Is there any idea about if there will be contrast enhanced tomosynthesis?
There is, actually some vendors have machines with contrast mammography combined with tomosynthesis, but I think they are not still FDA approved and not in sale, But there is, I have attended several lectures for some vendors that they use contrast mammography and then they image it with tomosynthesis. Any other question? So we continue. So now we've diagnosed the cancer using contrast mammography. We have staged this cancer using contrast mammography. We have treated the patient, and we are asked to follow up or determine if treatment works. The first use of contrast mammography in the follow-up is to confirm or exclude operative bed recurrence. And this is one good example. She's a 40-year-old female with right conservative surgery. She had this area with a parenchymal distortion corresponding to the operative bed scar. Based on her mammogram, we can never be sure whether this scar is a normal scar or whether there is operative bed recurrence. But when we look at the contrast mammography, just by a simple look, and we found that the whole length of the scar shows enhancing lesions, then this is definitely operative bed recurrence. This is another case. She had a right conservative surgery, and again, we have a distorting scar in the right breast, and this scar is associated maybe with fat necrosis. Again, based on the mammogram, we can never say whether there is recurrence or no, but looking on the contrast mammography, there was no enhancement at the site of the operative bed, and this was simply operative bed scar with the fat necrosis, but unfortunately, there was a coincidental carcinoma in the other breast. If you go back to her mammogram, the carcinoma was here, but it was not evident before we did the contrast mammography. This is another case. She performed a skin sparing operation and the tram flap reconstruction. The operative scar was distorted with microcalcifications. There was an asymmetry at the site of the scar. On the contrast mammography, as we see here, these are the microcalcifications, but there was no enhancement associating these calcifications. And as we said at the beginning of when we talked about the contrast mammography, then that if we find no enhancement, this means either there is nothing or there is an underlying benign lesion. And actually, this was simply a case of operative bed fat necrosis. Contrast mammography is also used in the follow-up of patients receiving neoadjuvant chemotherapy. Lesion, and so we can definitely say that there is complete radiological response of the retroareolar mass lesion. And again, we go back to the question, has contrast mammography solved all the problems of breast imaging? Because it combines, it gives us an enhanced morphology assessment, and in the same time, it gives us some functional information about the neovascularity, which associates malignant breast lesions. Definitely using contrast mammography has helped, but still we have an overlap between benign and malignant mass lesions, and contrast mammography does not give us any information about the metabolism of the tumor cells. And again, because necessity is the mother of all inventions, a new weapon had to be added to the diagnostic arsenal against breast cancer, and this time the weapon is the PET mammography. The positron emission mammography was approved also for sale by the Food and Drug Administration. PET mammography, or PEM, it is known as PEM, is a specialized application of PET used to visualize breast tissue changes. PEM is based on the same principles as PET, as it analyzes increased glucose metabolism in the cancer cells via an injected radio tracer. And to simplify how PEM works, I will just make a comparison between the contrast mammography and the PEM. In contrast, which is obtained in the CC, the mediolateral, and the axillary view. We have a new fixed PET mammography machine in Bahia Breast Cancer Hospital, but actually we'll start working with it next week, so I don't have cases to show. This is not my case, this is a case from the internet. It's just to show you how PEM gives us 12 images of tomographic images, and we can easily identify even small lesions as small as 1 millimeter or 2 millimeters, and this is a case of a multicentric carcinoma of the right breast. And lastly, to end my lecture, definitely in the last decade, we have witnessed the emergence of a new era in breast imaging, with the development of new technologies and the upgraded applications of already existing ones. Yet a question still remains: with this rapid pace of new developments, has the field of breast imaging exhausted itself, or should we still await even higher technical evolutions? And thank you. Any other questions?
معانا دكتور عبد الله.
Hello, doctor. How are you?
Yes.
I have a question regarding enhanced mammogram about the patient selection for this procedure. I saw some of the lesions are being speculated in conventional mammogram, but when we use a contrast enhanced mammogram, it reveals no enhancement, and this is reassuring about their benign nature or being just a scar tissue. So what is the sensitivity and specificity of contrast enhanced mammogram compared to conventional mammogram? And is it reassuring if we did contrast enhanced mammogram and it was negative or there is no enhancement, even in if the conventional mammogram is highly suspicious? Should we proceed for biopsy or an MRI, or it is quite reassuring that we can ignore this? We can take the enhanced mammogram confidently as if it is negative for enhancement.
As regards the sensitivity and specificity of contrast mammography, it's much higher than the mammogram. It approaches the MRI, and it is much higher than the normal mammogram. The specificity, especially of the mammography, is very low. In some, even in some studies, it reaches 30% and 40%. It's of very low. The mammography is a very low specificity. And the MRI also is of a low specificity, but actually the low specificity of MRI is of benefit, because the low what makes MRI of low specificity is that it sees many of the benign precancerous lesions which should be surgically removed. So it's a low specificity. It gives us a large number of false positive results, but these false positive results are of benefit to the patient. Okay, the contrast mammography increases the specificity and sensitivity of mammography, but nothing is without disadvantages or without any limitations. In some cases, I perform the contrast mammography, and then I tell them, no, I'm not sure, I have to perform an MRI. But these are very an example in Bahia Hospital, for example, we perform what approaches maybe 60 to 70 cases per week of contrast mammography, and sometimes even more than this. Okay, out of these 60 or 70, every 2 to 3 weeks, every 2 to 3 months, will I say that this contrast mammography is not enough? I need to perform an MRI in addition to the contrast mammography. You see the difference? It is not without limitation. One major advantage of contrast mammography is that it is very palatable to the surgeons. If you give the surgeon an MRI, he will tell you, tell me what's in this MRI. But in contrast mammography, he can have the film with him in the operative room, he can see the film, and he can understand what he sees in the film. So it has some advantages over MRI, but still never say that contrast mammography is better than MRI, because
Thanks دكتور عبد الله. Next وقت حضرتك يسمح دكتورة رشا؟
ما فيش مشكلة.
طيب دكتور تهامي, I've been unmuted you.
To Rasha.
Yes.
Thank you for your cases. They are, but I have a question. One of the cases that you showed in ultrasound was that the mass was highly vascular with high Doppler flow inside. However,
Yes.
in the contrast enhanced, it did not enhance and it became as a benign lesion.
Yes. You want an explanation to this?
Yeah, please, because what we know, if the lesion is highly vascular, mostly it is malignant and it should be very open.
Yes, I'll tell you something, that it's not only about the lesion being vascular. It's about the new vascularity, which has a deficient basement membrane, and they allow leakage of the contrast. You can have a benign lesion which shows vascularity, but this vascularity is healthy vessels. They do not leak the contrast in the surrounding parenchyma. You see the difference? The increased vascularity in pregnant lesions, they are new vessels which have a deficient basement membrane, and they leak the contrast. But this is a good point, because we have fibroadenomas which enhance, and you can. I'm not sure what is the technique, how they enhance, although they have healthy vessels also.
Oh, okay.
Thanks دكتور تهام. نود التنبيه على, بعد إذن الدكتورة رشا, نود التنبيه على السادة الزملاء والزميلات الأعزاء بالضغط على رابط الفيدباك لمراجعة وملء استمارة الفيدباك, لأن السادة المحاضرين وإحنا بنحتاجها في تطوير مستوانا وتلافي العيوب ومحاولة تعظيم المميزات. فرجاء ملء استمارة الفيدباك لأن إحنا بنحتاجها ضروري. جزيل الشكر. Next question دكتورة ماجدة مجدي.
محمد, دكتور محمد, I have a question, بس this lecture is recorded مش كده؟
أيوة يا فندم.
طيب عشان I need the record بعد after that يعني.
After your permission دكتورة رشا طبعا.
After your permission. I need just the record to keep it يعني with it.
طبعا يا دكتورة رشا. طبعا يا فندم. دكتورة ماجدة مجدي, اتفضلي يا فندم.
دكتور رشا.
Yes.
بعد إذن حضرتك يا دكتور, كنت عايزة أسأل في female patient 50 years old with PIRADS 5 breast lesion على background on ACRC breast density. Should I proceed to such cases an MRI to exclude multicentricity before this patient proceed to the operation?
يعني بصي, usually I wait to the decision of the breast cancer tumor board. If the surgeon tells me that this patient it is feasible for conservative surgery, and I cannot see, it's not just being an ACRC or an ACRD breast. There are an ACRC and ACRD breast where you can feel that the parenchyma is homogeneous, and even in these breasts you can identify that this is a single lesion. But it is about the heterogeneity of the breast parenchyma. If you have a heterogeneous dense parenchyma and you have a single lesion, and the surgeon says that he wants to perform a conservative surgery, then usually in these cases we proceed to a contrast study just to exclude that there are no other lesions in the breast. But if you're definite that this is a single lesion, or if the surgeon says no, she's a candidate for mastectomy, then we do not do anything more. There is no use of performing any other contrast study.
next candidate دكتورة ريهام حسن. اتفضلي يا دكتورة ريهام.
السلام عليكم دكتورة رشا.
وعليكم السلام.
من فضل حضرتك كان في بيبر نازلة جديدة في 2019 عن الاوتوميتد بريست التراساوند. فهل الجهاز ده موجود اصلا في مصر واحنا بنشتغل عليه؟
The automated ultrasound is present in the national screening program and it is present in the National Cancer Institute and وفي اللي هي الشيخ زايد، مستشفى الشيخ زايد اللي في مدينة نصر، وفي واحدة كمان بس أنا ناسية فين. يعني في عندنا 4 أجهزة في مصر automated breast ultrasound، واحنا مصريين كتير عاملين عليه studies كتير يعني.
تمام شكرا لحضرتك يا دكتور.
لا.
next question دكتورة شيماء أحمد علي. اتفضلي يا دكتورة شيماء. unmute yourself.
السلام عليكم دكتورة رشا.
وعليكم السلام.
دلوقتي احنا في السكريننج بروجرام اللي احنا ماشيين فيه دلوقتي في مصر، ازاي اخد القرار ان انا ابجريد بتاع الحاله، ان انا اوديها لتومو او اكتفي ان انا فعلا مش شايفه حاجه على المامو اللي انا شايفاها مع الالترا ساوند لو انا محتاجه؟ يعني في جايد لاينز امتى اعمل ابجريدنج للنكست ستيب؟
ما هي انت في اصل احنا السكريننج اللي احنا ماشيين عليه دلوقتي مش تبع الجايد لاينز قوي، يعني هو يعني زي ما تقولي حاجه
هي فكره الحاله اللي حضرتك عملتيها وبالتومو ابتدى يبان فيها حاجه ثانيه مختلفه، او الحاله اللي احنا اديناها الدينوفو عملنا الكونتراست. اقصد ان القرار بيتغير لما اخد خطوه اكتر، يعني الحاله اللي احنا كنا هندخلها كونسرفتيف سيرجري وعملنا لها الكونتراست فاخدنا غيرنا القرار.
لا بس دول
انا عايزه بوينت كده اخد عليها القرار امتى اشفت الحاجه اعلى.
طيب احنا لازم نفرق، احنا بنعمل سكريننج، we are performing screening or diagnosis. والسكرين انت بتساليني على السكريننج، وضع السكريننج دلوقتي في مصر ولا السكريننج اللي هو documented worldwide؟
لا الدوكيومنتد.
documented worldwide. If you have tomosynthesis you should include it in at least one view in your screening mammogram. خلاص. When you have a symptomatic patient, the condition is totally different. According to the symptom of the patient, we have specific guidelines for each symptom. يعني if you have مثلا nipple discharge, the workup of the nipple discharge is different from when you have a palpable mass lesion. If you have an inflammatory breast lesion, it's different from if you have مثلا كده. فكل symptomatic patient has her diagnostic workup. لكن if you are speaking of screening in general, if you have tomosynthesis, then include at least one view of tomosynthesis in your screening mammography. دكتور محمد هو لسه
حضرتك يا دكتورة رشا يعني لما حضرتك تقرري
زي ما هم عايزين يسألوا، لا ما فيش مشكلة خالص.
طيب يعني وقت ما حضرتك تقرري تنهي ما فيش اي مشكله. الساده الزملاء
5 raising their hands بنشوف هم مين ويعني
اوكي last five. طيب معانا دكتور محمد كمال محمد سعد. اتفضل يا دكتور محمد.
السلام عليكم. السلام عليكم.
وعليكم السلام.
شكرا يا دكتور رشا على المحاضره بتاعت حضرتك. بس كان ليا سؤال بالنسبه للكونتراست ماموجرافي، هل في بروتوكول معين بنستخدمه؟ يعني كونتراست الدوز هاو تو انجكت مانوالي ولا بانجكتور، ناخد قد ايه وقت ما بين الانجكشن والتصوير، كل ده في بروتوكول معين يعني عشان نمشي عليه؟
طبعا بروتوكول وستاندردايزد. يعني هو ما حد سالني عليها ولسه كنت مجاوبه عليها قبل كده. يعني احنا we inject contrast in the antecubital vein طبعا preferably using an injector. خلاص. بس in most places we do it manual. We have يعني human injectors and nurses بتوعنا. بس هو طبعا preferably ان هو يبقى using an injector. خلاص. وبنويت 2 minutes وبعدين بناخد السي سي والميديولاترال اوبليك بنبتدي بالنورمال بريست، ديزيز بريست، ديزيز بريست، نورمال بريست، يعني بنلف لفه حوالين العيانه خلاص، وبناخد وفي كل وضع من دول بيبقى فيه اللو الهاي انرجي ايمج، ده انت الجهاز هو اللي بيعملهم يعني.
next question دكتورة مروة شحاتة. دكتورة مروة شحاتة unmute yourself. دكتورة مروة.
السلام عليكم دكتورة رشا.
وعليكم السلام يا دكتورة مروة.
أنا بس كنت عايزة أسأل إيه الأدفانتج بتاع البيم over الكونتراست انهانسد ماموجرافي؟
بصي هو يعني هو لغايه دلوقتي احنا لسه، انا يعني ما عنديش قوي الاكسبيرينس فيه، احنا لسه هنبتدي نشتغل بيه، لسه الجهاز راكب ولسه هنبتدي نشتغل بيه. بس هو مثلا له ادفانتج، مثلا يعني نتكلم على الفولو اب اوف نيو ادجuvant patients مثلا. هو it detects changes in the metabolism before we see the morphology. يعني when you are following up a patient receiving neoadjuvant therapy, we wait until the size of the tumor changes so that we can say that this patient is responding or no. But if we do a PEM, even without any change in the size of the tumor, we can say that this patient is responding to the chemotherapy that we are giving. فمثلا sometimes we tell the oncologist that the patient is not responding, the tumor is the same size, there is no response, he adds another chemotherapy or he changes the drug that he's giving أو كده. when you know that these changes early, you can manage the patient. They say that we can even detect the changes after 2 weeks of giving the chemotherapy. So if you do this, you can tell the oncologist, yes, you are giving the right drug, no, you are not giving the right drug, add something or change something مثلا يعني. لكن يعني actually يعني I do not still have the experience to يعني ان انا اقول لك خبرتي فيه، لان انا لسه ما اشتغلتوش. واغلبيه الناس اللي كانت شغالاه يعني اغلبهم بتوع ايزوتوبس، فما عندهمش بالكونتراست ماموجرافي عشان يقدروا يقولوا لنا الفرق بينه وبينهم ايه. فغالبا احنا اللي هنطلع الخبره دي بشغلنا، يعني لما نشتغل هنبتدي نشوف الفرق بين ده وده او نعرف الفرق بين الاثنين.
دكتورة عائشة. دكتورة عائشة.
السلام عليكم دكتور عائشة. السلام عليكم.
وعليكم السلام.
Please, I want to ask, does normal breast glandular tissue of the breast enhances post-contrast?
يعني usually it doesn't. I did a study once about the correlation between the breast density and the amount of the background parenchymal enhancement, and I found that in contrast mammography there is يعني you can see a lot of dense breasts without any enhancement at all on the contrast mammography, on the contrast images. In some cases it does, but not very common. It's not very common. Yes.
Okay. Thank you. جزاك الله بخير.
وده كان اخر سؤال معانا النهارده. يعني نود التنويه ان النهارده طبعا كان الحضور قياسي. النهارده احنا معديين 500 طبيب وطبيبه من الساده الزملاء حضروا معانا النهارده، واضطرينا ان احنا ننقل لايف على الفيسبوك، والمره الجايه ان شاء الله هيبقى لايف على الفيسبوك وهيبقى لايف على اليوتيوب ان شاء الله. بنشكر حضرتك دكتوره رشا، وبنهني حضرتك وبنهني الساده.
ابعتوا لي بس يعني المحاضره بقى بعد كده يعني
ان شاء الله بعد اذن حضرتك طبعا، وهنبعت لحضرتك المحاضره وهنبعت الفيدباك. وبنشكر الساده الزملاء وبنطلب منهم تاني ان هم يملوا الفيدباك. استاذه دكتوره رشا بتحتاجه والساده المحاضرين بيحتاجوه. وبنهني حضرتك تاني بخطوه الايجيبشن سوسايتي اوف بريست ايميجينج، وبنتمنى الساده الزملاء اساتذتنا والساده الاستشاريين والاخصائيين والساده الزملاء ان هم يبتدوا يكونوا جمعيات اخرى للسب سبيشاليتيز وللتواصل وللتعليم المستمر.
انا بس باكد دكتور محمد ان هي يعني جزء لا يتجزأ من الجمعيه المصريه.
طبعا
عشان في ناس كانت فاكره ان احنا يعني جمعيه مستقله وبتاع، لا احنا مش كده خالص يعني. فاحنا بمجرد ان احنا تابعين للجمعيه المصريه للاشعه يعني بس.
واحنا هدفنا التعليم المستمر والتطور المستمر، ونبقى في يعني في الالحاق بركب العلم دايما، ومتصلين بالعالم دايما، واصغر نايب اشعه متصل باكبر استشاري اشعه موجود في العالم، بحيث ان الناس كلها تتعلم. وبنشكر حضرتك جدا دكتوره رشا، ومنتظرين حضرتك ان شاء الله في لقاءات اخرى باذن الله.
شكرا جدا ليكم كمان.
احنا اللي سعداء يا فندم، احنا اللي سعداء، الفيدباك رائع.
ويوفقكم والله على مجهودكم ده.
الله يبارك في حضرتك، الله يبارك في حضرتك يا دكتوره رشا. جزيل الشكر للساده الزملاء، وفي انتظار محاضرات قادمه للدكتوره رشا كمال والساده الزملاء، وكل سنه وانتم طيبين، والسلام عليكم ورحمه الله وبركاته.
مع السلامه.